Is it still on?
Hey everyone, we did our research project on cervical cancer. It's by Caitlin, Kayla, Reagan, and KJ. So, some background information and anatomy. So, the cervix consists of two parts, and there's also two different cell types. You have the endocervix, which consists of glandular cells. These cells help to produce mucus. And then you have the ectocervix, which consists of squamous cells. These are flat cells that can be found in tissues and organ linings. These two cell types converge at the transformation zone, and cervical cancer typically is found at this location in the beginning.
So I had our basic cancer research, and the cells of origin are the epithelial cells of the cervix, which are typically found on the ectocervix, representing about 70 to 90% of all cervical cancers. The less common, the adenocarcinomas of the glandular epithelial tissue on the endocervix represent about 25%, according to the American Cancer Society. So the subtype is further classified for these based on the strain of HPV virus. So we know that the cervical cancers are highly influenced by persistent HPV infections. So there's several hundred types of HPV viruses that are known, the strains, and 16 and 18 are oncogenic, so they're cancer-causing strains of the HPV virus. The HPV 16 strain is a common infection among the squamous on the ectocervix, and HPV 18 is the less common strain that affects the endocervix, causing adenocarcinomas. So the goal of any virus is to infect a host cell and cause replication of the viral DNA. And the HPV virus in cervical cases is no different. It takes persistent infection, though, and there's two major problems that happen with persistent HPV infection is the E6 and the E7 viral protein. And the molecular problem as far as the tumor suppressor gene is concerned, in a typical cancer cell, the tumor suppressor gene is mutated, so you may have an issue producing P53 or retinoblastoma. But in our case, our cancer, these proteins are degraded after they're translated. So the protein is made, but the E6 viral um, protein binds to that and degrades a P53. So then once cervical tissue replicates, you can't stop it. E7 does the same thing, but only it acts on the retinoblastoma protein. So can't hit the brakes once these start to divide. So here's kind of an image of how this would work. So thanks, Dr. Vodishka, for the picture. If you have some sort of DNA damage after persistent HPV infection in the cervix and P53 is produced, this E6 viral protein breaks it down, and then you can't get any sort of check on the cell, no cell cycle arrest or apoptosis. So E7, even if some of the P53 proteins were to survive and try to do their job, the later process of the cell cycle arrest, the retinoblastoma is affected by this E7 viral protein. So that process can't proceed either. And then the cell continues to divide, which is, can we go back a slide just real quick? So the hallmark of this here is the molecular change aids the virus to evade tumor suppression. That's what's affected here. Good there.
Okay, so a little bit about the drug that we chose. So Avastin is a monoclonal antibody that targets the VEGF-A, which stands for vascular endothelial growth factor A. VEGF-A is a glycoprotein that binds to VEGF receptors on the endothelial cells to promote angiogenesis. So, in cervical cancer specifically, tumors overexpress VEGF-A to develop their own blood supply to receive oxygen and nutrients, which leads to rapid tumor growth and metastatic spread. VEGFA is not a proto-oncogene, its upregulation leads to tumor promoting effects. So here's a little bit of a picture about how it works.
Cancer epidemiology, the public health issue, as per the American Cancer Society, is estimated that in the US, in just this year alone, about 13,360 new cases of cervical cancer will be diagnosed, and around 4,320 of those cases will turn up fatal. It is mostly diagnosed within women from the age range of 35 to 44, with the average age overall being around 50 years old. More than 20% of cervical cancer cases are diagnosed in women over 65 years of age, due to most women around that age don't realize that they are still very much at risk for breast cancer because there is no information targeted towards them. Incidence rates for cervical cancer declined more by half its numbers in the 1970s to 2000s due to more frequent usage of screenings as a secondary prevention, and for women aged 20 to 24, incidence declines about 11% each year because we are using now more than ever the use of primary prevention through vaccines. Mortality rates, like incidence rates since the 1970s when those screenings were more frequent, have been on a steady decline. However, mortality rates in white women are around 65% lower than POCs such as Native Americans and African Americans. An observational study that can be found on cervical cancer in relation to Avastin was conducted in Croatia with women aged 45 to 61 over the years 2016 to 2020. Risk factors included in this: when Avastin was used just by itself, it was at a much lower risk than when combined with chemotherapy, with just Avastin at 27% toxicity and chemotherapy combination at 50% toxicity. That was a grade 3 out of 4. And quality of findings and study strengths was safety assessments and understanding findings of newfound limits to cancer and beneficial to cancer research, as well as the data collections from the 6 oncology centers that were collected during this study with these women also helps researchers have more of an understanding in that area of what does and doesn't need to be done as far as cancer research focus areas.
Avastin is an FDA-approved drug to treat multiple types of cancers, including cervical cancer. It is specifically approved to treat cervical cancers that are metastatic, persistent, or recurrent. Avastin has shown increase in survival in cervical cancer patients, especially when used in combination with chemotherapy. However, Avastin is a very expensive drug, costing around $535 per cycle. It could cost around $167,000 per life year saved, with a 95% confidence interval ranging from 95,000 to 550,000. Lots of cancer treatments are increasing in cost, especially in the US. Since it is an effective treatment, the cost-benefit analysis kind of depends on the patient and what they are willing and can pay for treatment. So whether or not the side effects of Avastin outweigh the benefits is a question that kind of depends from person to person. So Avastin is proven to extend survival in cervical cancer patients, especially when combined with chemotherapy, by slowing down or stopping the growth completely of the cancer. So patients should consult with their doctors about what the best treatment is for them, and also pay attention to their side effects. So side effects can include hypertension, protein in urine, delayed wound healing, GI perforation, reduced platelet count, reduced white blood cell count, and thromboembolism. And so I also included a picture of kind of what cervical cancer looks like. So you can see a normal cervix and then kind of the early stages, and then you can see it progressing. So it kind of starts in that transitional area and then can spread.
So getting into the clinical research aspect, so there's three main subtypes for cervical cancer. The first one being squamous cell carcinoma, which makes up about 70 to 80% of this subtype. And this comes from the squamous cells of the transformation zone of the exocervix. And then you have the adenocarcinoma, which makes up about 25%. And this comes from the glandular cells of the endocervix. And then you have a very rare form, which is a combination of both, known as adenosquamous carcinoma. So for the prognosis, doctors typically use the 5-year relative survival rate. And this plan is based off of what percent of people have the same type and same stage of cervical cancer and are alive 5 years after their diagnosis when compared to the overall population. So in the early stage of diagnosis, you have about 91% chance of survival. When there's nearby spread, that decreases significantly to 60%. And then when there's distant spread, you have a very minimal chance of survival at only 19%. And then just overall, the 5-year relative survival rate for all people with cervical cancer is about 67%. So looking at the spread during each stage, so for stage one, which would be the top left, you're looking at a small amount of cancer only found in the tissues of the cervix. Really can only see these in the cells under a microscope. In stage two, it's found in the upper 2/3 of the vaginal and uterine tissues, which can be seen in this image here on the top right. In stage three, it's found in the lower third of the vaginal tissue or the pelvic wall. And typically in this stage, this is where you can start to see kidney problems as well as it entering the lymphatic system. And then in stage four, this would be more aggressive. This is when it tends to spread beyond the pelvis into the ladder of the into the lining of the bladder or rectum or other distant parts of the body. So for screening, I included a quote from the National Institute of Health, just kind of outlining what their goal is. So their goal that they determined would be to find precancerous cervical cell changes when treatment can prevent cervical cancer from developing. And the three main ways that they typically screen for cervical cancer is through an HPV test. This checks for cells that have infection. You also have the pap smear. This is more common. This collects cervical cells to look for changes. This finds both precancerous cells as well as cervical cell cancer. And then you have a combined test of the HPV and PAP test. Typically, screening starts around 21 years of age. And when you're in that age range of 21 to 29, it's recommended that after your first pap smear at 21, you follow that up every 3 years. If you're 30 to 65, the pap smear is every 3 years and the HPV test is only every 5 years. And then if you're 65 or older, you typically consult your physician, determine if you still need screening. If you're a high risk patient, they typically lean more towards screening, but for most normal people, you don't get screening after the age of 65. So for the treatment protocol, in the earliest stages, you usually use surgery, radiation, or a combination of both with chemo. Later stages, you're going to use radiation and chemotherapy. And then in the more advanced stages, typically just chemo. The neoadjuvant therapy that they would do would be chemo, so the paclitaxel plus cisplatin, followed by a hysterectomy for advanced stage patients. And then the adjuvant therapy would be the chemoradiation and surgery for more high risk patients. And some drug combinations that they found that work best would be our drug, the bevacizumab plus chemo. You've got paclitaxel and cisplatin, and then paclitaxel and topotecan. And the more common form would be the bevacizumab and chemo, and the paclitaxel and cisplatin. The paclitaxel and topotecan wasn't found to be as effective. So as far as the patient experience goes, some common side effects that they see would be like fatigue, anxiety, skin problems, diarrhea, nausea and vomiting, bladder discomfort, high blood pressure, and like low blood cell count. Patients also question which drug treatments and combinations were right for them. And then general shrinkage throughout most treatments were accompanied by fatigue just because the type of treatment that you typically use for cervical cancer is a little bit more aggressive. And they found that resistance to our drug was typically through abnormal methylation, more specifically hypermethylation. Genes are linked to carcinogenesis through this. You have cisplatin resistance, cervical cancer, which is linked to cervical adenocarcinoma drug resistance. And then you have mismatch repair, which typically corrects the base pair mismatches. But in resistance, it's found that the MSH2 contributes to cisplatin resistance, and lower levels of the MSH2 expression increases drug tolerance. And then they also saw VEGF resistance. So their rationale for developing this drug was pretty much that cervical tumors have increased amounts of vasculature and express VEGF at high levels to promote angiogenesis. And our drug, the bevacizumab, is what targets angiogenesis. It focuses on new levels, higher levels, and new blood supply. So that's kind of their rationale for developing the drug. The target molecule is VEGF-A ligand, and then the mechanism is that bevacizumab specifically targets the VEGF-A by binding to and neutralizing the molecule, and this prevents VEGF from being recognized and entering the cell, which leads to the cell not being able to proliferate and carry on through angiogenesis. This is just kind of a diagram explaining that. So you can see the VEGF molecule on the left here going through the cell through a normal process, leading to proliferation and angiogenesis. And then when you take our drug, bevacizumab, it blocks this molecule, and then it cannot enter the cell, and then there's no proliferation and angiogenesis. And so how specific is it? So this is a specific targeted treatment, so it does only really apply to the VEGF-A ligand. It's seen to work on similar isoforms, but really just this type of molecule. So what are its expected off-target effects, and why do they occur? So you have hypertension, which is high blood pressure due to this VEGF-mediated vasodilation. There's also bleeding and GI perforations due to impaired vascular repair, proteinuria due to VEGF inhibition in the kidneys. And the therapeutic index for this drug is pretty narrow just because there are really severe side effects. And it has the high effective dose, close to the dose at which there's serious adverse effects and toxicity. So this drug is typically only given every 2 to 3 weeks. And then these are our sources.